Good afternoon, ladies and gentlemen. May we ask you to settle down? We will begin the convention in a few moments. Before we start, we would like to ask everyone to join us in a solemn prayer, to be followed by the Philippine National Anthem and the PSEDM hymn.
Dear God, thank you for the opportunity to meet together. Please help us to come together to make this institution reflect your kingdom. Breathe life into our ideas and decisions. Help us build a team that has love and respect at its heart. Give us the strength to continue working for your kingdom in this time of pandemic. Lord, come give us the inspiration to be the best we can be. May we be a shining example of your goodness and truth within, wherever we are. Inspire our thoughts, discussions, and ideas, and continue to remind us that all that we do here today, all that we accomplish, is for the pursuit of truth for the greater glory of you. We ask these things in your name. Amen.
We made a vow to care for the sick, to give them the best our abilities can seek, because happiness to us is always being seen as a trustworthy friend. Together we function as a team, as a children's achievers, passionate about responsibility. And this is who we are at PSEDM. With integrity, excellence, commitment, care, caring, service, and respect. The values we hold dear, because we live in the pursuit of excellence. In this we adhere to the noblest standard of ethics in relating with people, in the practice of medicine, our mentors who enhance our knowledge and skills. We repay and contribute for these values and ideals. PSEDM, we set our vision high. Quality care, education, and research that could go on. Sharing knowledge with each other is what we endeavor. And this is who we are at PSEDM. With integrity, excellence, caring, service, and respect. The values we hold dear, because we live in the pursuit of excellence. In this
Maliwanag na pagbati sa inyong lahat. It is with great excitement that we at the Philippine Society of Endocrinology, Diabetes and Metabolic, our 60th Diamond Annual Carrot, current approaches, recommendations, advances, and trends in diabetes and endocrinology. We showcase illustrious speakers whose expertise will shed a light on the many different aspects of endocrinology and diabetes. The next few days will definitely be packed with scintillating lectures that will give us a diamond's 4 C's. Carrots of knowledge, colors of and a view towards cutting-edge technology in the practice of medicine. Come join us today. Honed and polished to brilliance, the PSEDM continues to blaze the field of endocrinology and diabetes.
It is my great honor to welcome all our distinguished colleagues, speakers, and participants to PSEDM's Annual Convention 2022. It is always a privilege to host an event that highlights important discoveries and discussions about the latest scientific data in endocrinology. We now accept the fact that we need to keep on learning through these events to keep abreast with changes in the medical field the COVID pandemic. This important event will coincide with the start of an anniversary. In line with our diamond anniversary, our theme for this year is Carrot. Current approaches, recommendations, advances, and trends in diabetes and endocrinology. We are hoping to give you a hybrid form is Carrot. Current approaches, recommendations, advances, and trends in diabetes and endocrinology. We are hoping to give you a hybrid form of the convention, but unfortunately, due to the current COVID situation, we are bringing the annual convention via digital platform. Nonetheless, we have made sure that the annual convention will be special and with many high-impact learning sessions. Our convention will start on March 17 and will run to March 19. Thursday, Friday, and Saturday, all sessions will start in the afternoon from 1 p.m. till 7 p.m. and there will be only 2 tracks per day. We made all topics compact to keep you connected and involved with every session. Furthermore, our scientific chair, Narvacan Montano, has created a comprehensive program that is relevant and stimulating. We have invited eminent speakers from the Philippines, Asia, and the United States to discuss topics in diabetes, thyroid, calcium, osteoporosis, and reproductive, and many more. We are supported by our friends in the ASEAN region through AFES. So, dear colleagues, I hope you stay on and happy listening, everyone. Keep safe.
Thank you, Dr. Villa. Next is Dr. Maria Encarnitas Blanco Limpin, President, Philippine College of Physicians.
The President and overall Chair of the PSEDM Convention, Dr. Michael Villa, to the PSEDM's officers on board, the past presidents, fellows, friends. This year is yet another milestone as we celebrate the 60 years of the Philippine Society of Endocrinology, Diabetes, and Metabolism. The society has gone a long way, and we've witnessed how you grew and expanded. As a mother, PCP can't help but be proud of you, and I cannot wait to see what becomes of you in the future. Of course, I envision you becoming stronger as you become more relevant and responsive to the needs of our people, especially those afflicted with various endocrine and metabolic disorders. So many things still need to be done. We know that diabetes remains to be a major cause of mortality and morbidity in the country. And during this pandemic, we even get to see COVID patients experiencing new diabetes and thyroid disorders, adding more problems to what we are currently experiencing right now. And these problems seem to persist and would definitely need to be managed properly. Added to these are the many areas of research that awaits to be explored. You are in the best position to address these problems. So we need to ensure that no Filipino with endocrine and metabolic disease will be left unseen and untreated. This is where you, PSEDM, and us in PCP can work hand in hand. PCP can work to increase the interest of internists in endocrinology so that more will aspire to go to endocrinology training. PSEDM, on the other hand, will have to expand further the number of training institutions so that we will be able to slowly close the gap on shortage of endocrinologists. Now, this is a problem that is not only unique in the Philippines. This has been a challenge in the other countries as well, including the developed countries. With all these challenges, the road ahead seems to be rough and tough, but I am confident that you will be able to deliver. PCP trusts you. PCP believes in you. And I would like to leave you this quote from a woman. I have always been in awe of strong and amazing women. And this quote comes from Marie Curie. Life is not easy for any of us. She says we must have the perseverance and above all, the confidence in ourselves. We must believe that we are gifted for something and that this thing must be attained. So to you, PSEDM, you have your goals. Stay focused on your goals. You have everything that you need. Just do your work and do it efficiently and effectively. I have no doubt that you can do it. Again, congratulations on your achievements and on your 60th year.
Thank you, Dr. Limpin. Now let's welcome the Vice President and Chair, Scientific Committee, 2022 Annual Convention, Philippine Society of Endocrinology, Diabetes and Metabolism Incorporated, Dr. Caroline Narvacan Montano.
Hello everyone. I hope you are all doing well and staying safe amidst the COVID-19 pandemic. The Philippine Society of Endocrinology, Diabetes and Metabolism is delighted to present the annual convention for the year 2022. We welcome you, our colleagues from all over the world, to join us as we celebrate the diamond anniversary of the Society. The celebration will commence on March 17 to 19, 2022 with a virtual conference with the theme PSEDM at 60, Current Approaches, Recommendations, Advances and Trends in Diabetes and Endocrinology. The objective of this meeting goes hand in hand with the PSEDM mission and vision of having well-trained and updated Filipino endocrinologists who serve the people through quality patient care, excellent education, and relevant research. The organizing committee was able to come up with timely scientific program and invited esteemed speakers from USA, Singapore, Malaysia, and Philippines. This 3-day event will start with a pre-convention. As part of the Society's vision to provide optimal health outcome for all endocrine patients, there will be 2 topics to update our members' training which will be relevant to our practices. The refresher course on radiation safety and workshop on ultrasound-guided evaluation and fine needle aspiration biopsy of thyroid nodules. For each of the 3 days, we will have plenary and symposia which will provide karat for our conference. The topics to be discussed will be diabetes, obesity, metabolism, nutrition, thyroid, adrenal and cardiovascular endocrinology, pituitary and neuroendocrinology, calcium and bone, reproductive and developmental endocrinology, endocrine-related cancer, and environmental endocrinology. There will be 8 state-of-the-art plenary lectures wherein our speakers will present the year's highlight which will impact patient care. The first plenary lecture will be given by the founder of the PSEDM, Dr. Augusto D. Letonwa, on the topic Defonso's Ominous Octet on Diabetic Kidney Disease. Plenary Lecture 2 will be on Case-Based Update on Endocrine Hypertension by Dr. William Francis Young of Mayo Clinic. Plenary 3 will be a clinical symposium on the impact of COVID-19 virus in the endocrine system. Our Filipino endocrinologists, who are pillars in the field, will focus on the emerging effects of persons with diabetes by Dr. Mary Ann Lim Abrahan, in persons with thyroid dysfunction by Dr. Schubertko, and in persons who are battling with obesity by Dr. Rosa Alonsi. These emerging topics will be the focus of their review. The Philippine Thyroid Cancer Guideline 2022 will be discussed by the President of the Philippine Thyroid Association and one of the past presidents, Dr. Menencio Nicodemus. Dr. Bart Clark of Mayo Clinic, who is an expert in the field of osteoporosis, will emphasize on the prevention and treatment of glucocorticoid and transplant-induced osteoporosis. Plenary 6 will be a multidisciplinary team approach in the management of a patient with complex disease. We have invited Dr. Zanaria Hussein of Malaysia for the endocrine role in the management of well-differentiated neuroendocrine neoplasm. Dr. Patricia Bautista Penalos will talk on theranostics, and chemotherapy will be discussed by Dr. Gerardo Cornelio, who is an oncologist. Discussion on the complex topic of cyclical Cushing, a vicious cycle of hypercortisolism, will be made by Dr. Susan Samson. She's also one of the educators in Mayo Clinic. And lastly, Plenary 8 will be on the topic of molecular thyroidology, a tool towards precision medicine. This will be discussed by an oncologic endocrinologist, Dr. Maria E. Cabanillas, who is associated with the Anderson Cancer Center. Now, topics of joint interest will be tackled in the 6 clinical symposia, which are integrated into 2 main concurrent practical streams. As you participate virtually at home, on-demand lectures will also be available for additional knowledge booster during this pandemic. Please be reminded to fill up and submit your evaluation forms during the course of the event. While we cannot meet in person, I look forward to welcoming you all and hope you will still have plenty of opportunity to exchange knowledge and build lasting memory and friendship during this virtual meeting.
Lectures that you can view anytime during the... Thank you, Dr. Caroline Narvacan Montano. There are 4 on-demand lectures that you can view anytime during the convention. Do not forget to view these exciting lectures. Browse through the research page for the latest Philippine endocrine and diabetes researches. Support our pharmaceutical sponsors by visiting their virtual booths and attending their sponsored symposia. There will be a daily raffle with exciting prizes. Please go through the raffle page for more details. Do not forget to fill up the daily evaluation form to get the full CPD units of the convention. These forms are available at the convention lobby. In a while, we will begin our scientific lectures. The esteemed Dr. Augusto D. Litonhua will be presenting Defronzo's Ominous Octet of Diabetic Kidney Disease with Dr. Jenny B. Aragon as chair and Dr. Claver P. Ramos as reactor. Let us now begin our plenary lecture 1.
It is my pleasure to introduce to you the first plenary speaker of this convention, Dr. Augusto D. Litonhua. He is called the father of Philippine endocrinology. He founded the Philippine Society of Endocrinology and Metabolism in 1961, the Philippine Association for the Study of Overweight and Obesity in 1994, the ACE Philippines in 2004, and together with his ASEAN colleagues has helped put up the ASEAN Federation of Endocrine Societies. He was past president of the Philippine Diabetes Association for 11 years, the Philippine College of Physicians, and also spearheaded the establishment of the Philippine Center for Diabetes Education Foundation, more popularly known as the Diabetes Center Philippines, where he is currently president. His contribution in the field of endocrinology have earned him the prestigious award, the Outstanding Service Award for the Promotion of Endocrine Health of an Underserved Population, given by the AACE in April 2007 in Seattle, Washington, and also received the International Clinician Award from the American College of Endocrinology in April of 2011. He's an emeritus professor of the College of Medicine, University of the Philippines, where he retired as professor and chairman of physiology, University of the Philippines, and also has been recently cited in a new grade 10 textbook, Exploring Life Through Science. Friends, please help me welcome Dr. Augusto D. Litonhua.
To introduce my lecture this afternoon with these few slides. Much of the morbidity and mortality of diabetes relates to the development of complications that affect organ systems such as the kidney. Diabetic kidney disease is a chronic progressive disorder that can lead to kidney failure and is currently the leading cause of kidney replacement therapy, both dialysis and transplantation. Let's take a look at this study about 10 years ago, for a period of 20 years, following the complications of diabetes in people with advanced 30% adult population with diagnosed diabetes. And as you can see, many of the complications show a downward trend over the year: acute infarction, stroke, amputation, death from hyperglycemic crisis. However, the events from end-stage renal disease is a plateau trend. So we haven't done much in those years of study towards eradicating end-stage renal disease. Let's take a look at the glomerular capillary wall. So the arterioles are here, and the basement membrane, inside it is the cortex, and then the endothelial cells around it too, the messenger cells. And then around the membrane is the podocytes, are the podocytes with the finger-like projections. And these podocytes are enclosed with glycocalyx again. Now, what is important here is these slit-like processes here that make the membrane permeable, for example, to proteins or aluminum. So there is a spatial glycocalyx here between the base of the food processes and the glomerular basement membrane. The slits, the size of the slits are affected by the food processes, and the charges to the slits are determined by the glycocalyx. So let's see how the diabetic disease progresses. First is the development of glomerular hyperfiltration and hypertrophy, followed by thickening of the glomerular basement membrane, mesangial matrix accumulation, development of nodular glomerulosclerosis, albumin excretion because of the widening of the slits and the lessening of the charges from the glycocalyx, and then the progression to kidney failure. So let's talk about the ominous octet for diabetic nephropathy of Dr. Ralph Defonso. I say Dr. Defonso's ominous octet because this octet is not universally accepted as yet in comparison to the ominous octet for hyperglycemia, which he developed so many years ago. Now, We know that Dr. Defonso is an endocrinologist. On what authority, may one ask, can he speak about diabetic nephropathy? He says that aside from being an endocrinologist, he is also a nephrologist, having discovered the SGLT2 transporters in the kidney. In fact, he says, had he patented that discovery, he would have been a very rich man today. So in an article of January 2020 identified dysfunction, mitochondrial injury, autophagy, fibrosis that reduce the features of the and are intraglomerular members, while Dr. Defonso removed inflammation and fibrosis from his ominous uptake, because in fact, in several articulation, and then we have the metabolic, which means poor glycemic control, which is benefited by the SGLT2 inhibitors, agonists, and the other anti-hyperglycemic agents. And then they have inflammation and fibrosis, in which they said there was no executive time primarily targeting inflammation and fibrosis. So let's take a look at the ominous uptake. Can not discuss this in his article last January 2021. But I would presume that, for example, there are some physicians which show that some diabetics who have not been intensified in their glycemic control have very few don't have kidney disease, whereas those who have a very good glycemic control have DKD or diabetic kidney disease. And these observations can probably be attributed to genetics. So let's go to hyperglycemia. Hyperglycemia is the predominant factor underlying the development of DKD. Patients with A1C within the normal range of less than 5.7% do not develop DKD, whereas microalbuminuria occurs in 15 to 20% of individuals with prediabetes, those whose A1C is between 5.7 to 6.4%. When the A1C exceeds 7%, the incidence of microalbuminuria begins to rise steeply and progressively over time. These are the effects of hyperglycemia on the kidney. When we have normal glycemia, glucose is broken down via glycolytic pathways. When there is hyperglycemia, however, the reduction of glucose is several pathways which are non-glycolytic. So we have the aldose reductase pathway, which converts glucose to sorbitol and then to the polyol flux, and then down to increase in oxidative stress to activation of PKC and several hexosamine pathways and advanced glycosylation end products. So protein glycosylation, which causes advanced glycosylation end products, causes altered albumin levels in the kidney, activated advanced glycosylation end products in the kidney, inflammatory cytokines, and several growth factors. Activation of the diacylglycerol pathway, increasing PKC, altered gene expression, increasing growth factors in inflammatory cytokines. Hexosamine pathway increases protein modifications, increases growth factors. And then lastly, this mitochondrial flux increases superoxide radicals, oxidative stress, and protein and DNA damage. So all of these five pathways will ultimately increase the mesangial matrix, podocyte damage and loss, tubular interstitial fibrosis, glomerular sclerosis, albuminuria, and decreased glomerular filtration rate. What are the evidences that show that intensive glycemic control has beneficial effects on kidney function? One, the DCCT reduced the incidence of albuminuria by 50%. This beneficial effect persisted for more than a decade after completion of the trial. The UKPDS in patients with type 2 diabetes demonstrated that it's about 1% reduction in A1C reduced the risk of complications by 37%. Specifically, the risk of microalbuminuria was decreased by 33%. The action in diabetes and vascular disease and the action to control cardiovascular risk in diabetes trials also showed significantly lower rates of albuminuria with intensive glycemic control, although this was in patients without diabetes and advanced nephropathy but with DKD from other causes. So how do we control glycemia? We know all of this, but I want this to emphasize the fact that the newer drugs, SGLT2 inhibitors, GLP-1 receptor agonists, are not truly anti-diabetic drugs because they have greater beneficial effects on the heart and on the kidneys. And several authors have labeled them as cardio-renal drugs instead of anti-diabetic drugs. Now we go to hypertension. After hyperglycemia, hypertension is the next most important factor that contributes to the progression of DKD. Normotensive patients with advanced DKD show slower progression of kidney disease than do patients with hypertension. However, the optimal blood pressure target for patients with DKD has long been a subject of debate. So, for example, the American Diabetes Association and the Joint National Committee 8 recommend blood pressure less than 140/90 millimeters mercury for patients with diabetes and less than 130/80 for individuals at high risk for cardiovascular disease. The American Heart Association and the American College of Cardiology joint 2017 guidelines recommend a lower target of less than 130/80 millimeters mercury for all individuals with diabetes and CKD. The Action to Control Cardiovascular Risk in Diabetes study targeting a systolic blood pressure target of less than 120 millimeters mercury, however, failed to reduce cardiovascular events in patients with type 2 diabetes and were therefore associated with increased rates of hyperkalemia and elevations in serum creatinine level. SPRINT showed the benefit of targeting lower blood pressure systolic BP of less than 120, although they recruited mainly non-diabetic elderly patients with kidney disease. So that the optimal blood pressure target to maximally slow or prevent progression of DKD in patients with established kidney disease is unknown. Now, how do we treat hypertension in people with type 2 diabetes and DKD? RAS blockers with ACE inhibitors and ARBs. The renin-angiotensin-aldosterone system, which is activated in the setting of diabetes, plays a central role in the development and progression of DKD, in part inducing efferent constriction and intraglomerular hypertension, and by activating a variety of downstream pro-inflammatory and pro-fibrotic pathways. RAS inhibition decreases the efferent arterial resistance and consequently decreases intraglomerular pressure and suppresses other non-hemodynamic injury pathways. Unfortunately, RAS blockade reduces but does not completely normalize hyperfiltration and does not fully prevent renal decline. Because of this phenomenon, angiotensin escape and aldosterone escape. This is the inability of ACE inhibitors and ARB to reduce the circulating angiotensin 2 in terms of angiotensin escape and circulating aldosterone in case of aldosterone escape to undetectable levels in both instances. So the second treatment for hypertension in DKD in diabetics is MRA receptor antagonists, spironolactone and eplerenone. Why? They reduce albuminuria when used alone and produce additional anti-proteinuria benefits when added to ACE inhibitors or ARBs. And then finally, SGLT2 inhibitors, which produce mild intravascular volume depletion. I would emphasize mild because some nephrologists think that when you have hypovolemia, that SGLT2 inhibitors are the cause of this. And number two, by inhibition of the sympathetic nervous system, is tubular growth factor hypothesis. Tubular and glomerular hypertrophy are characteristic features of DKD and are predictors of decline in GFR and poor renal outcomes. Angiotensin 2 is a potent growth factor that contributes to glomerular hypertrophy independent of its vasoactive effects. Insulin-like growth factor 1, platelet-derived growth factor, vascular endothelial growth factor, epidermal growth factor, all have been implicated in proximal tubule hypertrophy and thus could contribute to the increase in proximal tubule sodium reabsorption. Then you have transforming growth factor beta 1, secreted by proximal tubules, inducing cell proliferation, migration, differentiation, and extracellular matrix turnover. TGF-beta levels correlate with proteinuria and A1C and are elevated in the glomerulus during early and late type 1 and type 2 diabetes. Connective tissue growth factors stimulate cell adhesion and migration, augments the production and deposition of extracellular matrix proteins, and promotes fibrosis by activating intracellular signaling molecules in mesangial cells such as receptor, tyrosine kinases, and TGF-beta. Now we go to the deranged tubulo-glomerular feedback. A series of elegant studies performed over 30 years ago demonstrated the important role of glomerular capillary hypertension in the progression of kidney disease. Sodium chloride delivery to the macular dense cells of the juxtaglomerular apparatus has a central role in the regulation of GFR and intraglomerular pressure through the phenomenon of tubulo-glomerular feedback. For example, when there is decreased sodium chloride delivery to the macular dense cells of the juxtaglomerular apparatus, this activates renal aldosterone and causes efferent vasoconstriction. And then there is a decrease in the release of adenosine, which is a potent vasoconstrictor, so causes vasodilatation in the afferent arteriole, causing increased intraglomerular pressure. On the other hand, when there is an increased sodium chloride delivery to the macular densa, this will decrease your efferent vasoconstriction because there is no stimulation of aldosterone. And then the release of adenosine will now release the arteriole from vasodilatation and cause its somewhat vasoconstriction. In diabetic kidney disease, what happens? There is an increase in filtered sodium chloride, and there is an increased glucose and sodium chloride reabsorption. So there is a decreased delivery of sodium chloride to the macula densa and causes afferent arterial vasodilatation due to the decrease and efferent arterial vasoconstriction because of the increase in angiotensin and aldosterone. And that causes an increase in capillary pressure, causing glomerular hypertrophy, tubular hypertrophy, and glucosuria. In this lecture, the effects of SGLT2 inhibitors on these different features of the aminos of PET. So, when we have diabetic kidney disease, what happens when we give SGLT2 inhibitors? Then we reverse vasodilatation because of the decreased glucose and sodium chloride reabsorption via inhibitors. We reverse vasoconstriction, so we promote normal glomerular capillary pressure. And so through this macular density, which is one point in which SGLT2 inhibitors act on, will normalize our kidney function somewhat. Now we go to hypoxia. Hypoxia is a characteristic feature of DKD, and it has been implicated in the development and progression of kidney disease. Sufficient oxygen delivery to the kidney is critical to generate ATP required for transporter function. What are the facts? Oxygen consumption in the kidneys is second only to the heart, 2.7 millimoles per kilo per minute, in comparison to the heart, which is 4.3 millimoles per kilo per minute. The renal blood flow is very high, accounting for 1/4 of the cardiac output. So these are the effects of diabetes on oxygen delivery and demand in the kidney. You have increased renal plasma flow, increased glomerular filtration, so acting on the macular densa, increased glomerular capillary pressure, the filtered glucose and sodium chloride is increased. There is proximal tubular hypertrophy. So what are the results of this? Increased angiotensin, which increases your growth factors, inflammation, fibrosis, oxidative stress, together with that produced by the proximal tubular hypertrophy. Then you have, then that causes loss of peritubular capillaries and shunting of blood to the medulla from the cortex, causing hypoxia in the cortex. Then you have resistance to the hypoxia-induced factor 1 alpha, causing decrease in the production of erythropoietin and, of course, anemia. Then because there is increased tubular reabsorption of sodium and glucose, there is increased intracellular concentration of sodium, which activates the sodium-potassium pump, and that requires a lot of oxygen, again causing a decrease in the PO2 in the kidney cells. The resulting exacerbation of hypoxia in turn stimulates the production of fibrotic and inflammatory molecules such as TGF-beta and TNF. Now, as an aside, perhaps this is the reason why Dr. Defonso removed fibrosis and inflammation in his ominous octet, because fibration and inflammation are the results of these ominous octet features rather than the primary cause of kidney damage. So now we go to the effects of SGLT2 inhibition on hypoxia. SGLT2 inhibition causes a normalization of the renal plasma flow and GFR, normal glomerular capillary pressure, decrease in filtered glucose and sodium chloride, and reversal of hypertrophy. So therefore, decrease in angiotensin and decrease of the growth factors, so decrease in inflammation, fibrosis, and oxidative stress. And then there is an increased sensitivity to the hypoxia-induced factor 1 alpha, causing an increase in erythropoiesis and improved tissue oxygenation. Because there is not much sodium intracellularly, then there is no activation of the sodium-potassium pump, and that leads also to increased PO2. Now we go to podocyte dropout albuminuria. Both charge and size, as we said previously, limit the filtration through the glomerular capillary wall. In patients with DKD, increased albumin excretion is mainly the result of the alterations in the glomerular filtration period. So here, podocyte injury is denoted by either a decrease in the number of podocytes or the detachment of the foot processes from the glomerular basement membrane. When this happens, these foot processes die, and then the adjoining foot process will cover up the area which was vacated by this death or detachment of the preceding foot process. This will increase the size of the pores. And then there is glycocalyx damage, which will alter the charge also of the pores, causing albumin to go out of the glomerulus into the tubules, which in turn causes tubulointerstitial injury. Albumin is bad for the tubular cells. SGLT2 inhibitors improve insulin sensitivity in the podocytes, and they potentially prevent podocyte injury and reduce albuminuria in DKD. Empagliflozin has been shown to augment podocyte autophagy, preventing podocyte effacement, detachment, and death in a mouse model of DKD. The increase in podocyte autophagy was associated with reduced mesangial expansion, improved glomerular histology, and decreased albuminuria. Now we go to obesity and lipotoxicity. Obesity, independent of diabetes, dyslipidemia, and hypertension, is associated with the development of chronic kidney disease, characterized by glomerular hypertrophy, mesangial expansion, glomerular sclerosis, and podocyte injury. So here we see the lipotoxicity affecting all the components of the glomerulus, mesangial cell, podocytes, in the glycocalyx, in the glomerular filtrate, and in the tubular cells. All this will cause injury to the glomeruli. So these are the effects of SGLT2 inhibitors on obesity and lipotoxicity. We know that SGLT2 inhibitors uniformly produce a weight loss up to 2 to 3 kilos during the initial 6 to 12 months of therapy ameliorating obesity. SGLT2 inhibitors cause a shift in substrate utilization from glucose to free fatty acids. This shift would induce a reduction in intracellular levels of toxic lipid metabolites, such as fatty acid, protease, glycerol, and ceramides. And it will reduce also, or the inhibitors will also reduce oxidative stress, endoplasmic reticulum stress, and pro-inflammatory and fibrotic processes. So these are the features of the onus of death for diabetes nephropathy, and also how SGLT2 inhibitors produce beneficial effects on the kidneys when we use them. Thank you very much for your kind attention. In this pandemic era, please stay safe.
Thank you, Dr. Litonghua. It is also my pleasure to introduce to you our action from Dr. Claver P. Ramos. He graduated Doctor of Medicine from University of the Philippines and had his residency in internal medicine in UPPGH. He proceeded to have fellowship in nephrology under Dr. Arnold Relman in Boston University Medical Center, and then Dr. Belding Scribner at University of Washington. He serves as a board of trustees of the Tropical Disease Foundation, a member of Council of Past President of the Philippine Society of Nephrology, past President of the Philippine Society of Nephrology, past President and board member of National Kidney and Transplant Institute, and presently affiliated at Makati Medical Center and Asian Hospital and Medical Center. Friends, please welcome Dr. Claver P. Ramos.
Thank you for inviting me to react to the excellent lecture of my professor, Dr. Litonghua. I'd like to focus on one item among the many items discussed by Dr. Litonghua, namely the fibrotic complications of diabetic nephropathy. Before we go on with the lecture, we have to document the fact that interstitial fibrosis is an independent risk factor. This was in fact proven by Dr. Yuan in this particular slide, studying 396 patients and followed up with at least 12 months over a mean duration of 29 months to check whether interstitial fibrosis in fact is an independent variable. In this particular slide, it says by multivariate analysis that both glomerular lesions and interstitial fibrosis are independent variables and closely equally independent variables compared with each other. As you see, the hazard ratio for glomerular lesions is 1.49 and 1.51 for interstitial fibrosis. For the p-value 0.011 and p-value 0.028 for renal survival. In the next slide, we see the doubling of creatinine by multivariate analysis, whether glomerular is independent variable and intestinal fibrosis as independent risk factor as well. The results show that both glomerular lesions and interstitial fibrosis are independent variables. Hazard ratio 1.38 for glomerular lesions and 1.45 for interstitial fibrosis. P-value 0.02, p-value 0.03, meaning that glomerular lesions and intestinal fibrosis are equally independent variables, as important as each variable is. In these 396 patients, mean duration of follow-up of 29 months. We don't have data on biopsy of patients follow-up over several years or several months on fibrotic analysis. But in the heart, we have, in human, we have observations in the heart for fibrotic complications in the heart. In this particular case, 8 patients with hypertension with severe fibrosis biopsied transjugularly to observe the amount of fibrosis in the heart with losartan over 12 months. You will note that the collagen volume fraction, the second set of bars, there's a remarkable decrease of collagen with losartan over 12 months. This is p-value 0.05 and significant at p-value 0.05. The left ventricular stiffness with losartan over 12 months, as you note in this third set of bars, has diminished. As you see, the p-value of 0.05. And the resiliency of the heart is also increased, which means it is softer and more flexible. The rise in TDEC means the heart is more resilient, all because of losartan in patients with severe fibrosis over 12 months. This is resemble regression of myocardial fibrosis after biopsy observed over 6 months in 18 patients. You will note that the EA ratio has increased over this 6-month period, which is an improvement. The IVRT has decreased, which is the relaxation time of the left ventricle. Decreased means an improvement in terms of the heart. And AWD means the heart is more resilient. It has increased from a level of 14 to a level of 24 in this particular set of data in 18 patients. The hydroxyproline level has also decreased, p-value of 0.001, which is a manifestation of decrease in fibrosis in the heart. As I said, there's no data on humans for biopsy picture of patients on treatment or without treatment. But there is data on chemistry studies in this particular case, 1,715 patients over a mean duration of follow-up of 2.6 years by Lewis et al. You will note here in the middle slide that irbesartan is much better than placebo, improvement 32.6% versus 39.0%. And compared with placebo, amlodipine was no different from placebo. But irbesartan was better than amlodipine in the third set of slide data, 41% versus 32.6. The message in this slide is that angiotensin receptor blocker is much better than placebo, much better than amlodipine at p-value 0.02 and 0.006. There is data in animals in terms of biopsy of animals. In this particular case, regression of spontaneous nephropathy in the Munich Wistar frontier rats with angiotensin II antagonism. You will note that at 25 weeks, 40 weeks, collagen accumulation is 2.1, 2.4. If you add lisinopril and valsartan from the 25th to the 40th week, the amount of collagen decreases from 2.4 to 1.3 at the 40th week, which is significant at a p-value of 0.001, meaning that in this spontaneous nephropathy in the Munich Wistar frontier rats, there is regression of collagen accumulation, regression of fibrosis in these rats. In this model of tubulointerstitial damage in subtotally nephrectomized rats, observed at 8 weeks, at 12 weeks, and then the third set of experiments, 12 weeks, with added enalapril from 8 weeks to 12 weeks. We note that the extent of tubulointerstitial damage has decreased from 1.16 to 0.63 in the experimental group with enalapril given at 8 weeks to 12 weeks. As you will note, 0.63 is even better than 1.16, which means that the enalapril in fact caused regression of lesions with observation of 8 to 12 weeks. My last message is that blocking of ACE and blocking of the angiotensin II receptor is a very important part of the treatment of diabetic nephropathy, not only of the diabetic nephropathy, but even of fibrosis in the heart as well. And in my opinion, this is my recommendation, we should always use angiotensin II receptor blocker in all our patients with diabetic nephropathy. Thank you.
Thank you very much. That was Dr. Claver Ramos for his reaction, and we are live for our Q&A. You can, of course, give your questions. Dr. Litonja is also here live to answer your questions. You can type it in the chat box or in the Q&A box of your accounts. So, can you hear me? Can you hear me? Okay, so thank you, Dr. Ramos, and you can type in your questions in the chat box or Q&A. Dr. Litonja is here to answer your questions live. So maybe, Doctor, we can get a reaction from what Dr. Ramos has said. Do you give SGLT2 inhibitors and the ARB together in your patients to protect the kidneys? And are these effects additive?
Yes, I would give them simultaneously because the ARBs and the ACE inhibitors correct a different feature of the omnibus of death, whereas the SGLT2s correct almost 6 of the 8 omnibus of death features of diabetic nephropathy. The only thing that the SGLT2 inhibitors do not benefit is genetics, of course, and the tubular growth factors. But all others are benefited by the use of SGLT2 inhibitors.
Okay, so with that statement, would you say, Doctor, that we can recommend starting SGLT2 inhibitors for most of our patients? How about in patients who have no DKD? Will there be advanced benefit to the kidneys in these patients?
Well, most say that we should use the SGLT2 inhibitors initially when there is presence of albumin in the urine over the normal values. So in my particular case, I use the urinary albumin creatinine ratio as my starting point for the use of SGLT2 inhibitors.
Okay. How about, doctor, if the albumin creatinine ratio is not available? So, for example, if one is practicing in the province or in a locality where albumin creatinine ratio is not readily available, what else can we use to look for DKD?
Well, the reason that the incidence of ESRD hasn't gone down like the other complications of diabetes is because we had no SGLT2 inhibitors before. We depended on the correction of the hyperglycemia and the hypertension.
Okay.
That was all that we could do then.
Yes.
Of course, diet. No?
Yes. Okay. So, doctor, how early? So, let's say we start a patient on SGLT2 inhibitor, already has proteinuria, for example, or the creatinine is already going up. How soon do we expect the benefit to the kidneys? And are there subset of patients who will not improve? Or are there predictors of patients who will not improve on SGLT2 inhibitors?
Yes. I think I will derive my answer from the empagliflozin study on the heart incidence of complications. No? You will see from the EMPAREG outcome study that the benefits of empagliflozin were very almost instantaneous upon the inhibition of SGLT2 inhibitors. And in fact, there was in EASD 2021 a report histologically that when you apply empagliflozin to the blood vessels, there is almost an instantaneous vasodilation that you will observe. So maybe I don't have any study that shows that there is an immediate, there is a longer period of results on the kidney function. But regarding the histologic study on the kidney vasculature, I would imagine that there would be an instant benefit histologically, no? But I don't know if this can be seen clinically.
Okay. So,
the question I think that cannot be answered is, at what point in the kidney disease stage are all medications useless? In other words, at that stage, we cannot do anything anymore, except, of course, dialysis and transplantation.
yes.
I don't think there is any answer to this as well.
Okay. All right. We have a question here. How about, Dr. GLP receptor agonists? What can you say about GLP receptor agonists like liraglutide? Do these medicines also have a role in protecting the kidneys?
Yes, they do have some protection in the kidneys. But again, I would like to refer to EASD 2021, where there was a debate. No, this was in regard to the 100 years of insulin discovery. Now they're looking at 100 years of the use of the GLP-1 receptor agonist and its SGLT2 inhibitors. And the question of the debate was, which one will endure? Will it be the GLP-1 receptor agonist or the SGLT2 inhibitors? And I think the positivity of the debate was towards the SGLT2 inhibitors because they were the only ones that could protect the heart and the kidneys very well. Whereas the GLP-1 receptor agonists protect the heart, but not the kidneys as well.
Okay, well said, Doctor. Another question here regarding the transient increase in creatinine with SGLT2 inhibitor. How would you address it? And would you discontinue or hold the drug temporarily? So we
I'm sorry,
know that
I'm sorry I didn't get the first part of the question.
Doctor, we know that there is a transient increase in creatinine, especially when we're starting SGLT2 inhibitors. How would you
Yes.
address this? And would you discontinue or hold the drug temporarily?
I don't think I can answer that very well, but I would not discontinue the SGLT2 inhibitors because that is only a temporary phenomenon in the use of the SGLT2 inhibitors.
Okay,
The, increase in creatinine.
yeah, so there is a transient increase in
So it's a transient
creatinine. Yeah.
Yes.
But there is no threshold wherein you will stop it.
I cannot answer that. I don't know.
Okay. All right. So, are there any other questions? So, there's another question here. So, good afternoon. If you have a patient, stage 3 CKD, already on SGLT2 inhibitor, and the GFR is deteriorating to 25 ml per minute, would you still recommend to continue the SGLT2 inhibitor? Thank you for your opinion. Much appreciated.
The GFR is 25.
Yes, when it goes down to 25.
I think the DAPA Heart study shows that you can use the SGLT2 inhibitors up to an eGFR of 20. And they were, yes, 20. And they were rather optimistic that it could also be used beneficially to below 20, although there was no hard proof on that as yet. But they were very optimistic about the beneficial effects of SGLT2 inhibitors.
So I guess we can still use it off-label, doctor, because most of the SGLT2 inhibitors would say to use it until GFR of 30. But if you're gonna use it beyond 30, it can be off-label, but there is promise, right, doctor?
Yes. But, well, because what is the main effect of the SGLT2 inhibitors? It's to decrease the reabsorption capacity from 180 to 20, no? So I don't think that the GFR will matter much in that.
Okay. So, are there other questions?
I am not a diabetic, but I use SGLT2 inhibitors for my heart failure. My blood glucose is very normal, 110, 180, but my sugar is 4 plus in the urine.
Okay.
Because
Yeah,
the SGLT2 inhibitors decrease the reabsorption, TM, I think, to 20.
So I agree with you. So we can also use already the SGLT2 inhibitors even in non-diabetic patients for the indication of heart failure. Yes, thank you. All right. So I think there are no more questions in the chat box. Let us now proceed to the giving of certificate. So, Philippine Society of Endocrinology, Diabetes and Metabolism awards the Certificate of Appreciation to Dr. Augusto D. Litonhua, our father of Philippine endocrinology, in grateful appreciation for graciously sharing his valuable time and endeavor as speaker during this 2022 PSEDM Annual Convention, March 17, the first plenary lecture signed by Dr. Caroline Narvacan Montano, the Vice President and Chair of the Scientific Committee, and our President, Dr. Michael Villa. Once again, Dr. Litonhua, thank you very much for sharing your expertise. And to all the listeners here, thank you for attending and stay tuned to the next plenary lecture. Bye.
Good afternoon, everyone. I'm Dr. Pete de la Peña, and I'm tasked to introduce to you a very esteemed speaker for our today's plenary. He is the Tyson Family Endocrinology Clinical Professor and Professor of Medicine in the Mayo Clinic College of Medicine at Mayo Clinic in Rochester, Minnesota, USA. He is the recipient of multiple education awards and is a past president of the Endocrine Society and past chair of the Division of Endocrinology at the Mayo Clinic. His clinical research focuses on primary aldosteronism and pheochromocytoma. He has published more than 300 articles on endocrine hypertension and adrenal and pituitary disorders. He has delivered more than 650 presentations at the national and international meetings, and he has been an invited visiting professor for more than 150 medical institutions. It is a privilege and my honor to introduce to you our speaker for endocrine hypertension, Dr. William Young.
Thank you very much, Pete, for that introduction. It's an honor to be invited to participate in your annual meeting. As Pete said, I'll be discussing endocrine hypertension. With regard to this presentation, I have no relevant financial relationships, and I'll not be discussing off-label drug usage. So we'll start with primary aldosteronism. This is the adrenal hypersecretion of aldosterone, but it's independent of renin. So patients present with high blood pressure, increased aldo, and low renin levels. Two most common causes are unilateral aldosterone-producing adenoma or bilateral idiopathic hyperplasia. So compared to before 1981, when primary aldo was thought to be rare, with a simple case detection test of measuring aldosterone and the renin in the morning, followed by confirmatory testing, we recognize that the prevalence of primary aldo is actually quite high. 5 to 10% of all people with high blood pressure have PA. And if a patient has resistant hypertension, more than 20% have primary aldo. So why is diagnosing PA important? Well, patients with PA have a 4 to 12-fold higher rate of myocardial infarction, stroke, CAD, and arrhythmias. And they also have poor health-related quality of life. All this is compared to people with garden variety genetic polygenic hypertension, independent of blood pressure control. So this is aldosterone specific. So in view of the high prevalence in the hypertensive population, with so much to gain, we should probably be testing for PA a lot, right? It's actually a sad state of affairs. In the Stanford Health System, only 2.1% of over 4,500 patients with resistant hypertension were screened for PA. In the University of Minnesota Health System, only 4.2% of over 18,000 people with resistant hypertension were screened for PA. Remember, 1 out of 5 people with resistant hypertension have primary aldo. University of Chicago Health System, only 2.7% of patients were screened for PA that had hypertension hypokalemia, only 2.7%. In the province of Alberta, Canada, they looked at all their patients with hypertension, and only 0.7% had been tested for PA. So how should we address this problem of underdiagnosis of primary aldo? This is not unique to the United States. This is happening across the world. It's an article I published in 2019. And here's just a screenshot of a paragraph from that article. Over more than 3 decades, it's been frustrating to see patients who are not tested for PA when they were first diagnosed with hypertension, but rather only after they've developed irreversible stage 4 or 5 CKD. Clinical practice guidelines have not been effective in driving more clinicians to consider case detection testing for PA. Could these guidelines be too complicated with regard to rules on meds, focusing on those high-risk subsets? The diagnostic algorithm should be simplified. All people with high blood pressure should be tested for PA at least once. So this is the algorithm I included in that article. All patients with hypertension should be tested at least once for PA. Why is that? Well, first of all, no one's testing for PA, so we need a way to start testing. And only 30% of patients with PA are hypokalemic. There is no phenotype. This is not like Cushing's syndrome, where you walk in the room and you're suspicious of an adrenal disorder. It couldn't be more simple. If you can test for hypothyroidism, you can test for primary aldo. Morning blood tests measure aldosterone and renin. That's all. If aldosterone's generous, not abnormal, but generous, greater than 10 nanogram per DL, and renin is inappropriately low, so PRA less than 1 or plasma renin concentration less than 8, that's a positive case detection test. Patient can be on any sodium diet, any blood pressure medicine. Don't stop any blood pressure medicine. Don't stop ACE inhibitors, ARBs, spironolactone, or eplerenone. Nothing causes a false positive test. Now, that's a case detection test. That doesn't prove your patient has PA. At that point, you need to prove it with a confirmatory test. Yeah, Mayo Clinic would do that with a 3-day generous sodium diet and measure aldosterone in the urine along with sodium. Now, you don't need to do that confirmatory step if your patient has spontaneous hypokalemia and aldo over 20 and suppressed renin. There's nothing else it can be. 4 confirmatory tests, you can do the saline suppression test, captopril stim test, fludrocortisone suppression test, or what we use at Mayo Clinic, the oral sodium loading test. Now, a patient with low renin, when the 24-hour urine sodium is greater than 200 milliequivalents, and the 24-hour urine aldo is greater than 12, that confirms primary aldo. You've made the diagnosis. Now the question is, does the patient have unilateral adrenal disease or bilateral? If they have unilateral disease due to aldosterone-producing adenoma, APA, and they have surgery, you'll normalize the hypokalemia in all patients, you'll improve hypertension 90%, and you'll cure hypertension in about 40%. Whereas if the patient's bilateral hyperplasia, unilateral adrenalectomy does not cure PA, and bilateral adrenalectomy is not a good trade. So patients with bilateral hyperplasia should be treated medically. So if a patient wants to pursue that surgical option, we need a good way to distinguish between unilateral and bilateral disease. So we start with an adrenal-dedicated CT scan. If you find a solitary, hypodense, unilateral macroadenoma, so greater than a centimeter, but not too big, and the contralateral adrenal is normal on every cut, and if the patient's young, less than 35 years of age, and if the patient has severe PA and aldo over 30 spontaneous hypokalemia, in that small subset of patients, we can consider going straight to surgery. Over age 35, because of the prevalence of incidental adrenal nodules, you can't trust CT scan. So 95% of our patients with PA are older than age 35, or they have non-localized CTs. So we need another test to tell us if the patient has unilateral or bilateral adrenal disease. So let's just review a case. This is a patient I saw in December, 57-year-old man, hypertensive for 6 years. This is just a screenshot from my clinic note. Spontaneous hypokalemia noted in the past, 3.3. He had an aldo of 16.5, suppressed renin, recheck 17.7, suppressed renin. And that was, suppressed renin was despite treatment with an ACE inhibitor and a diuretic. That's really impressive. If I took an ACE inhibitor and a diuretic, my renin would go through the roof. Patients with PA, it's hard to make renin budge no matter what drug they're on. Now, he was also taking a calcium channel blocker, diltiazem. He's on an alpha-1 antagonist, doxazosin, and 40 milligrams lisinopril per day and 12.5 of hydrochlorothiazide. So here's his adrenal CT. This is cut high up. Here's the very top of the right adrenal gland. It appears normal. It appears normal, looks normal. You're starting to see the top of the left adrenal gland. These adrenal glands are looking normal. Normal. Appears normal. No nodules seen in either adrenal. Only thing I saw was just a slight bump in the inferior aspect of the right adrenal. As the adrenals come to the tip, they should get more slender, not chubby. So I thought that was just curious. It was looking a little chubby there, but that's not much of a finding. The left adrenal keep normal. Now the right adrenal is disappearing. Left adrenal is normal, normal, normal. Now our radiologist said no discrete nodule, and I agree. That tiny bump I saw on the right, I can find in a lot of people that don't even have adrenal disease. So here's the rest of that clinic note. CT was completed. Today I reviewed the images with Andy. He has a small nodule inferior aspect of his right adrenal. Otherwise, the adrenals appear quite normal. When he was treated a short period of time with eplerenone, he had dramatic blood pressure response, and he's keen to pursue the surgical option. So this is where we need another test, and that's adrenal vein sampling. When we do adrenal vein sampling, the first question, was the radiologist successful in getting in both adrenal veins? That's your first question. So you divide the cortisol level from the adrenal vein on the right, 505, and you divide by 16. You can see the gradient's 31.6-fold. You're looking for a gradient more than 5-fold. And on the left, 215 divided by 16, 13-fold. And that's pretty typical. Usually it's nowhere near 5-fold. Next question, does the patient have unilateral or bilateral disease? Well, it's pretty obvious just looking at the data set, but I'll just take you through the arithmetic. You divide the site aldosterone level by the site cortisol level. So left adrenal vein, 140 divided by 215, 0.7. Right adrenal vein, 5,200 divided by 505, 10.3. IVC, 15 divided by 16, 0.9. Then you divide the high side, the dominant side, on the right, 10.3, by the non-dominant, 0.7. And you get a gradient of 15 to 1. Anything more than 4 to 1 says unilateral disease. So it's coming from that right adrenal gland. So I met with him the day before surgery. Potassium was normal, reviewed the homegoing plan. We cut or discontinue any drugs that could lead to hyperkalemia post-op. So in this case, I cut his lisinopril in half to 20 milligrams a day. I cut the doxazosin in half to 2 milligrams per day. Continued on diltiazem and hydrochlorothiazide post-op. Told him to monitor blood pressure daily. Our target is high normal blood pressure, 140 over 90 for that first month after surgery. We don't want him to be pre-renal for the first month after surgery. I advised Andy to get a blood potassium, sodium, creatinine once a week for 4 weeks. About 5% of patients develop clinically important hyperkalemia with a potassium greater than 5.2, and they require short-term treatment with fludrocortisone. Andy had CKD. Patients with primary aldo are hyperfiltrating, and the creatinine looks better than it actually is because they're hyperfiltrating. So after surgery, and you correct the hyperfiltration, creatinine goes up. Something important for patient to know about and all the physicians to know about. So he had his adrenalectomy on January 6th. Indeed, there was a little nodule, 8-millimeter nodule in that right adrenal. And the proof that we've cured him is measuring aldosterone the day after surgery. It was undetectable. Here's a 4-week follow-up from February 4th of this year. I just listed his meds prior to surgery. and how we sent him home on half dose of doxycycline, half dose lisinopril. He's been monitoring his blood pressure daily. He stopped his doxycycline and hydrochlorothiazide, and lisinopril is down to 5 milligrams a day. So he's only on 5 milligrams lisinopril a day and 240 of diltiazem. And his blood pressure is averaging 130/90. This is a fantastic response to surgery. So surgery was January 6th. These were pre-op labs. And remember, he's hyperfiltrating here. And post-op, you can see creatinine rose above normal. It'll probably stay there. It won't go any higher. Serum potassium has remained high normal. So he does not need fludrocortisone. And he's very, very pleased with this post-op course thus far. So to summarize the treatment of primary aldosteronism, if the patient has an aldosterone-produced adenoma or unilateral hyperplasia, PAH, laparoscopic adrenalectomy, fantastic treatment option. It's an outpatient procedure in most patients. Bilateral idiopathic hyperplasia, treatment of choice is an MR antagonist. It can be a selective MR antagonist like eplerenone or non-selective like spironolactone. If needed for blood pressure control, we add a thiazide diuretic, calcium channel blocker, an ACE inhibitor, or ARB. There's a subset of patients with IHA that's severe and asymmetric on AVS, and you can consider unilateral surgical debulking in these patients. And there's a subset of patients with unilateral adrenal disease that decline surgery, in which case they need to be on an MR antagonist. The correct dose of spironolactone, which is a once daily drug, or eplerenone, which is a twice daily drug, is whatever it takes to give you a high normal potassium without the aid of potassium supplements. Whatever the dose is that you need to give to achieve that goal. So let's move on to pheochromocytoma. So it's a catecholaminergic tumor, usually localized to the adrenal. Unfortunately, physicians think about pheo much more than they think about primary aldo. They think about it a lot, they look for it a lot, but they're not going to find it very often because this is a rare tumor. However, when correctly diagnosed, properly treated, it's curable. When undiagnosed or improperly treated, it can be fatal. It's rare, 0.01 to 0.1% of the hypertensive population, equally in men and women, primarily third through fifth decades. In 2022, symptoms are present in the minority of patients. If they are present, they can come in spells or paroxysms. So what I'm hinting at is the mode of diagnosis has changed over the past 100 years. And now 60% of all adrenal pheos are discovered as adrenal adenomas on cross-sectional imaging. Just to provide more data to support that. It's a publication of ours from 2019. We're looking at percent of patients on the y-axis and 4 different data sets on the x-axis. From 1926 to 1970, we had 138 adrenal pheos. 1971, 1980, 106 adrenal pheos, and so on. Those that presented with the classic presentation of hypertensive paroxysms with palpitation, sweating, headache, pallor, 90% of all patients, that's how they presented in the old days. 84% up till 1980. Only 51%, 95 to 2004. In this most recent series, only a quarter of them. Whereas in the blue bars are those that are discovered incidentally. In the old days, it was like incidental discovery on a kidney x-ray or at surgery for some other reason like cholecystectomy. But now, 61% of our patients were discovered on cross-sectional imaging done for other reasons. Abdominal mass has always been a rare presentation for pheo, and genetic family testing, that percentage is increasing, and now it's up to 12%. So once we suspect our patient may have a pheochromocytoma, so if they do present with that classic pheo spell, episodes of forceful palpitations, diaphoresis, headache, sweating, tremor, pallor, sure, test them for pheo. But even most of those patients don't have pheo. Resistant hypertension, 3 drugs, poor control. Just like we should be testing for PA, we should test for pheo. If they have a familial syndrome that predisposes to FEO, like MEN2 or von Hippel-Lindau, they should have annual biochemical testing. Family history of FEO. Anytime I see a brand new FEO patient, I want to test all first-degree relatives because we still don't know all the genetic causes. Incidentally discovered adrenal mass. That's rich territory to find FEOs. It's 61% of all adrenal FEOs at Mayo Clinic. About 2% of all adrenal incidentalomas will prove to be pheochromocytoma. If they have a pressor response to anesthesia, surgery, angiography, high-dose steroid, for example, an 8 milligram overnight dexapression can cause a FEO crisis. And onset of hypertension at a young age, you can draw that line wherever you like. I use about age 30. In terms of case detection testing, it'd be great if none of our patients took any drugs, but that's not realistic. The good news is all blood pressure meds are okay. Alpha blockers are okay. Beta blockers are okay. Don't stop any blood pressure medication. What does interfere are psychotropic meds, especially tricyclic antidepressants. Cyclobenzaprine, which is used as a muscle relaxant in the United States, is actually a tricyclic. So treatment with tricyclics, antipsychotics, if possible, should be tapered and stopped at least 4 weeks before testing. Sometimes that's not possible to stop those. It's not realistic to stop them, in which case we go ahead and test. If our labs are normal, you're golden. That patient doesn't have a FEO. And finally, you need to take into account the clinical circumstance. So you can't diagnose FEO in the ICU biochemically. Everyone in the ICU has high catechols and metanephrines. So this is an important table. This is a list of drugs that cause false positive elevations in norepinephrine, normetanephrine. Number 1 on my list, tricyclic antidepressants. These are endogenous catechols. There's an overflow. You'll pick it up in any blood test, any urine test. 2 to 10-fold elevated. Levodopa, dopamine levels are 10 to 20-fold elevated. Drugs containing adrenergic receptor agonists like decongestants, usually less than 2-fold elevation. Amphetamines, a variable effect. Buspar antipsychotics, 3 to 10-fold elevation. Norepi, normetanephrine. Serotonin, norepi, reuptake inhibitors, up to 4-fold elevation, whereas SSRIs, less of an impact, less than 50%. Compazine, a variable effect, reserpine, 3 to 10-fold elevation. Withdrawal from codeine and other drugs, variable effect. Ethanol withdrawal, variable effect. But again, with our current assay methodology, which is either tandem mass spec or HPLC, antihypertensive drugs are not a problem. It's all about the meds on this slide. Having said all that, 60% of pheochromocytoma patients are initially detected as adrenal incidentalomas. And when they're small, typically less than 1.5 centimeters, the factor is not big enough to make enough catechols to give you a positive biochemical test. So it's key for endocrinologists to know what a FEO looks like. And I refer to this as imaging phenotype. So a very simple thing is measuring the unenhanced CT attenuation in Hounsfield units. The lower the unenhanced CT attenuation, the more lipid, the more likely a benign adenoma. Whereas the higher the unenhanced CT attenuation, the less lipid, could be a FEO, adrenal cancer, metastatic disease. So the pre-contrast radiodensity is less than 10 HU. That's an adenoma. Now, could we make cortisol? Could we make an aldosterone? But it's not a FEO. Whereas if the unenhanced CT attenuation is greater than 20, in this case 41 HU, look out. That's something bad. In that case, that is a pheochromocytoma. So here's a study we participated in. It's a multi-center study with 548 confirmed pheochromocytomas. 376 of these pheos, for which we had unenhanced CT attenuation, had data available. 374 out of 376, the unenhanced CT attenuation was greater than 10 Hounsfield units. The 2 exceptions, exactly 10 Hounsfield units. So the message here is really simple. Within your system, simply draw a region of interest around the adrenal mass In this case, it's lipid poor. Unenhanced CT attenuation is 35.2. You bet that could be a FEO, regardless of the biochemical test results. Whereas nearly identical appearing right adrenal mass here has an unenhanced CT attenuation of 1.2. It can't be a FEO. It's impossible. Don't test for FEO. You're going to get stuck with false positive testing. So less than 10 HU can't be a FEO. Don't screen for FEO. So the messages here are simple. In a patient with adrenal incidentalloma, the very first thing you should do, even before I see the patient, look at the imaging phenotype. It directs 90% of what I do. Small FEOs can be pre-biochemical, rely on imaging phenotype. So let's just go over a case. 39-year-old woman, 8 months ago, she had a contrast-enhanced abdominal CT for abdominal pain. They stumbled over a 1.3 centimeter left adrenal mass. Normal blood pressure, rate stable, no adrenal-related symptoms. In the past, she'd been diagnosed PCOS and adult attention deficit disorder. Her medications included metformin, oral contraceptive pill, and methylphenidate. Her blood pressure was normal, heart rate normal. She was overweight. Serum potassium was normal. So here's that scan from 8 months ago. And like many initial scans, it's going to be contrast enhanced with no unenhanced images. So if you draw a region of interest, in this case, you get 81.4, but that's with contrast, and that really doesn't help you very much. We need to know the unenhanced CT attenuation. She was screened for subclinical Cushing's. The 1 milligram overnight dex was normal. DHA sulfate is 146. We published a paper recently showing that if your DHA sulfate's over 100, it's unlikely your patient has subclinical Cushing's. You probably don't need to do the overnight dex suppression test. She was screened for FEO. Plasma metanephrine was normal. Normetanephrine normal. 24-hour urine metanephrine was normal. Metanephrine was normal. 24-hour urine no epi, and dopamine. All normal. Everything's normal. I always go back and look at old images, see if I can see how long an adrenal mass has been present. This was a scan she had 11 years ago. I thought that adrenal was slightly thickened, but our radiologist thought it looked normal. That's the scan from 8 months ago. So now we got an unenhanced, updated, current CT. So you can see, look at that mass. You can see how dense it is compared to the kidney. That's going to be dense. If you draw a region of interest, unenhanced CT attenuation is 38.4 HU. Whatever that is, it's not good. That's a lipid poor mass. It measures 1.9 by 1.3. 8 months ago, it was 1.3 by 1.1. So it's grown. Lipid poor, growing. Not good. Here's my clinic note. Let's see. I share with the patient her mother today. I suspect she may have a FEO based on the imaging phenotype and the fact that her plasma metanephrine was close to being abnormal. It wasn't abnormal. It was close. We'll go ahead, start on doxazosin at bedtime, get preoperative testing next week, introduce her to endocrine surgeon. If this proves to be a lipid poor adenoma, I still think it should come out. It's a lipid poor mass. It's growing. She's only 39 years old. It's not going to go away. It's grown over a fairly short period of time. She understands and recognizes the rationale behind the recommendation. I gave her an article on adrenal incidentalomas and a brochure on FEO. So she goes to surgery, 2 centimeter mass. There's the cut section. Yep, you bet. That's a pheochromocytoma with normal biochemistry. And here's the deal, guys. Pheochromocytomas don't just suddenly appear. They grow slowly. Now that people are getting cross-sectional imaging for all sorts of reasons, we have plenty of cases where we've documented how fast FEOs grow. I'm just going to show you one of these. This patient's going to grow a FEO in that left adrenal gland. Here's a scan a year later. Now it's getting a little plump. Here's a scan that's 3 years later. Now a definite nodule in that left adrenal that's vascular, and 4.5 years later. It's only at this point the radiologist noticed that there's an adrenal mass. And actually, right there, biochemical testing was normal for pheochromocytoma, but that's a FEO. In terms of genetics, there's 3 general pathways for developing pheochromocytoma. There's a hypoxic signaling pathway, which we refer to as cluster 1. These patients have noradrenergic or dopamine secreting tumors. Two most common genes in this category are the succinate dehydrogenase family and von Hippel-Lindau. Then there's the kinase signaling pathway, or cluster 2. These patients have adrenergic tumors, so epinephrine, norepinephrine, two most predominant ones, RET proto-oncogene, MEN2, and neurofibromatosis type 1. And finally, the least common, cluster 3, is the Wnt signaling pathway. That's actually quite rare. The good news is 95% of causative germline pathogenic variants are going to be SDH, von Hippel-Lindau, RET, and NF1, and occasionally MAX and TMN 127. This is a graph we published in New England Journal of Medicine 2019. I like this because it shows what mutation is most likely based on the decade within which the patient was diagnosed, and also based on age, what's the likelihood you're going to find a germline mutation. So a percent of patients on the y-axis, the decade of life is on the x-axis, that's first decade, second decade. So you can see the first decade of life, von Hippel-Lindau is the most common genetic disorder. And you can see 85% of people presenting up to age 10 have a germline pathogenic variant in some gene. Second decade of life, VHL is still common, but SDHB is becoming more common. Third decade of life, SDHD is the most common, followed by RET proto-oncogene. Now, interestingly, that gray part of each column increases with each decade. These are patients without mutations. So the older the patient, the less likely they're going to have a pathogenic variant. 40% of all patients with pheo and paraganglioma have a disease-causing germline mutation. As I mentioned, typically present at a younger age. We should consider genetic testing in all people diagnosed with pheo and paraganglioma, especially if it's a paraganglioma. Bilateral pheo is always genetic. Unilateral pheo and a family history of pheo, always genetic. Unilateral pheo in a young age, more likely genetic. So here's my summary slide. Primary aldo, it's common. Most patients have a normal potassium. Test for it. I think all people with high blood pressure should be tested at least once. Couldn't be more simple. A morning blood test for aldosterone and renin. Don't worry about medications. Don't worry about ARBs, ACE inhibitors, diuretics, MRIs. Don't stop anything. Nothing causes a false positive test. Don't trust CT scan in people over age 35. And find or develop a good adrenal vein sampling program and an expert adrenal surgeon. With regard to pheochromocytoma and paraganglioma, now this is rare. Most positive case detection tests are going to be false positive. And it's going to be norepinephrine, norepinephrine. Know those drugs that interfere. Psychoactive agents, not blood pressure meds. Incidental adrenal mass, it's all about imaging and phenotype. And when you do have that patient with pheochromocytoma or paraganglioma, consider germline genetic testing. I thank you very much for your attention. I'd be pleased to address any questions that may have arisen based on this presentation.
Thank you very much, sir, for a great lecture you delivered. It is absolutely brilliant on tackling key points on endocrine hypertension, especially primary aldosterone releasing and pheochromocytoma. So my first question to you, sir, is for us in the Philippines, it is not cost-effective to perform a complete evaluation for secondary hypertension in every hypertensive patient. Are there any clinical tools that suggest to a particular type of secondary hypertension, as you mentioned in primary aldosteronism and pheochromocytoma?
Thank you for that question, Pete. So if you were to try to focus on subgroups that are at higher risk for primary aldo, for example, in other words, if the cost is prohibitive to test everyone with hypertension, then in the endocrine society guidelines, we did highlight those high-risk subgroups, which is resistant hypertension, 3 drugs per control. 1 out of 5 has primary aldo. Or hypertension, hypokalemia, even if the patient's not on diuretic, high chance that patient has primary aldo. Onset of hypertension at a young age, less than 30 years of age, should test for primary aldo. So those would be the 3 subgroups that I would, if I was limited to who I could test for PA, that I would test. As I showed, though, in the United States, clinicians, even those high-risk subgroups, they're not testing for primary aldo. So we have a problem.
Okay, so are these clues that you mentioned, severe hypertension, We've seen an acute rise in blood pressure, age less than 30 in Lagana obese or accelerated hypertension, warrants total workups and a referral to a tertiary hospital. But in our setting in the Philippines, especially in the islands, if we suspect for a primary aldosteronism, is it prudent for us to start an aldosterone antagonist in the form of spironolactone?
So if resources are scarce and testing is limited, I would have a very low threshold to start an MR antagonist, spironolactone or pleuronone. These are very effective antihypertensive agents, obviously in primary aldo, but it turns out it's a very good antihypertensive class for general hypertension too. So I think they should be used much more around the world than they've been used thus far.
Okay, thank you very much, sir, for that. The Philippine Society of Endocrinology, Diabetes and Metabolism awards the Certificate of Appreciation to Dr. William Young as a speaker during the 2022 PSEDM Annual Convention with the current approaches, recommendations, advances, and trends in diabetes and endocrinology. It's signed by our Vice President, Rafaela Carol Narbacan Montano, PSEDM Chair, Scientific Committee, together with our President, Dr. Michael Villa. Thank you very much, sir, for this very wonderful lecture.
Thank you, Pete. It was a delight to be here with you today.
We invite everyone to attend one of the 4 industry-sponsored symposia. We invite everyone to attend one of the 4 industry-sponsored symposia. We invite everyone to attend one of the 4 industry-sponsored symposia. There are 4 on-demand lectures that you can view anytime during the convention. Do not forget to view these exciting lectures. Browse through the research page for the latest Philippine endocrine and diabetes researches. Support our pharmaceutical sponsors by visiting their virtual booths and attending their sponsored symposia. There will be a daily raffle with exciting prizes. Please go through the raffle page for more details. Do not forget to fill up the daily evaluation form to get the full CPD units of the convention. These forms are available at the convention lobby. There are 4 on-demand lectures that you can view anytime during the convention. Do not forget to view these exciting lectures. Browse through the research page for the latest Philippine endocrine and diabetes researches. Support our pharmaceutical sponsors by visiting their virtual booths and attending their sponsored symposia. There will be a daily raffle with exciting prizes. Please go through the raffle page for more details. Do not forget to fill up the daily evaluation form to get the full CPD units of the convention. These forms are available at the convention lobby. There are 4 on-demand lectures that you can view anytime during the convention. Do not forget to view these exciting lectures. Browse through the research page for the latest Philippine endocrine and diabetes researches. Support our pharmaceutical sponsors by visiting their virtual booths and attending their sponsored symposia. There will be a daily raffle with exciting prizes. Please go through the raffle page for more details. Do not forget to fill up the daily evaluation form to get the full CPD units of the convention. These forms are available at the convention lobby. There are 4 on-demand lectures that you can view anytime during the convention. Do not forget to view these exciting lectures. Browse through the research page for the latest Philippine endocrine and diabetes researches. Support our pharmaceutical sponsors by visiting their virtual booths and attending their sponsored symposia. There will be a daily raffle with exciting prizes. Please go through the raffle page for more details. Do not forget to fill up the daily evaluation form to get the full CPD units of the convention. These forms are available at the convention lobby.
Good day, doctors and delegates. Our session is a continuing medical education grant from MSD in the Philippines. Our speaker is the immediate past president of the Philippine Association for the Study of Overweight and Obesity. She is the past president of the Philippine Society of Endocrinology, Diabetes and Metabolism, a senior lecturer of the Department of Biochemistry and Molecular Biology at the University of the Philippines College of Medicine, University of the Philippines, Manila. And she is also a graduate of the certificate program on the Introduction of Clinical Research Training, Harvard Medical School Postgraduate Medical Education. To discuss Do Not Be a Statistic, Shield from Diabetes During This Pandemic, Dr. Mia Fojas.
Good day, everyone. I have entitled this presentation as a warning Do not be a statistic. Shield yourself from diabetes during this pandemic. These are my disclosures. Okay. This is the outline of this presentation. And on the left, you can see the Anderson Labs encapsulated beta cell. Okay, it's so cool. So this is the outline. I'll first show you statistics on diabetes, and then we'll talk about the pathophysiology of diabetes in relation to COVID-19. And we'll talk about, we'll touch something more about moving towards remission in diabetes. I think some of you have seen this slide in some presentations already, but I would like to stress this one out, that on the upper right part, that's the Western Pacific region, and that's where we are. And you can see that there's a 27% increase in the prevalence of diabetes from 2021 to 2045. This seems small compared to the other continents. However, if you take a look at the numbers, we have the highest, one of the highest prevalence of diabetes in the entire globe. And here, this is again based on the IDF 2021 Atlas. These are the estimates and projections of the global prevalence of diabetes in 20 to 79-year age groups in millions. And this compares the IDF Atlas from the 1st to the 10th edition. On the right side, that's in red, you are shown the prevalence of diabetes among adults from year 2000 to 2021. Here. And the purple graph shows the projected prevalence in millions. Notice that in 2003, the projected prevalence was 333 million, and in 2006, it was 380 million for the year 2025. However, if you compare the data to the left, as of 2021, we already have surpassed the 500 million mark. This does not even include new onset diabetes that was due to COVID-19. Diabetes does not seem to increase the risk of COVID-19 occurring in this slide. However, diabetes was seen as more frequent in patients with severe COVID-19. And this was published in year 2020 in the Lancet. In this table, diabetes mellitus increased the risk of mortality or severe disease 2 to 3-fold. More so among people with poor glucose control. In this table, people with hyperglycemia, glycemic control should be ensured to reduce the risk of death and of threatening metabolic complications like ARDS, acute kidney injury, and heart injury. The precise mechanisms behind the development of new onset diagnosis in people with COVID-19 are not known, but it is likely that a number of complex interrelated etiologies are responsible, including impairments in both glucose disposal and insulin secretion, stress hyperglycemia, pre-admission diabetes, and steroid-induced diabetes. The relationship between diabetes and COVID-19 is biunivocal. In one hand, people with diabetes have worse outcomes because of multiple associated conditions enhancing this risk. On the other hand, SARS-CoV-2, because of its tropism for the beta cell, might cause new onset diabetes or sustain hyperglycemia at hospital admission. The impairment of beta cell function, along with the inflammatory cytokine storm and counter-regulatory hormonal responses, can precipitate further acute metabolic complications such as diabetic ketoacidosis or hyperglycemic hyperosmolar state. Now that we know about COVID-19 worsening diabetes mellitus and causing new onset diabetes mellitus, Are there COVID-19 therapies that have interactions with anti-hyperglycemic agents? This table shows the advantages and disadvantages of anti-hyperglycemic agents when particular treatments are used for COVID-19. Patients admitted to hospitals for severe COVID-19 might need modifications to their diabetes therapy, including withdrawing ongoing treatments and initiating insulin therapy. Such a decision should be based on the severity of COVID-19, nutritional status, actual glycemic control, risk of hypoglycemia, renal function, and drug interactions. Although insulin treatment has been recommended in patients with diabetes with severe COVID-19, one study showed worse clinical outcomes and a worse laboratory results profile in patients on insulin compared with those on metformin. Nonetheless, these results should be viewed with caution because of potential confounders by indication, as insulin treatment could have been used simply because the diabetes was more severe. In keeping with this hypothesis, another study that showed that insulin infusion allowed the achievement of glycemic targets and improved outcomes among patients with hyperglycemia and COVID-19. Despite better outcomes reported in patients with COVID-19 with diabetes treated with metformin, the drug should be stopped in patients with respiratory distress, renal impairment, and heart failure because of a risk of lactic acidosis. A favorable effect of metformin among patients with COVID-19 has been hypothesized that the drug might prevent entry of the virus into the target cell via adenosine monophosphate activated protein kinase activation and the phosphatidylinositol 3 kinase protein kinase B mammalian target of rapamycin signaling pathway. Moving on, DPP4 inhibitors are associated with a low risk of hypoglycemia and can be used for a wide renal function range. DPP4 inhibitors are generally well tolerated, and in experimental studies, they were shown to mitigate inflammatory response. Because soluble DPP4 might act as a co-receptor for a subset of coronaviruses, DPP4 inhibitors might interfere with and modify such binding and hypothetically reduce virulence. However, there's no clinical evidence of such an advantage, and in two studies, no association was found between individual glucose lowering drugs and outcomes. In here, you can see that there is no drug interaction among patients treated with lopinavir, ritonavir, or atazanavir. A hypothetical antiviral effect, of SGLT2 inhibitors has also been suggested, as these agents can decrease intracellular pH and increase lactate concentrations that could reduce the viral load. Nonetheless, SGLT2 inhibitors require optimal hydration to avoid hypovolemia and electrolyte imbalance and proper adjustment of insulin doses because of the risk of diabetic ketoacidosis. GLP-1 receptor agonists might aggravate anorexia and should be discontinued in severely ill patients with COVID-19 because of a potential risk of aspiration pneumonia. Nonetheless, preclinical studies have suggested that GLP-1 receptor agonists might attenuate pulmonary inflammation and preserve lung function in rats with experimental lung injury and respiratory syncytial virus infection. Because of the risk of hypoglycemia, sulfonylureas should be stopped in patients with diabetes with COVID-19, particularly if oral intake is poor or if chloroquine is simultaneously used. Pioglitazone has anti-inflammatory properties, and in experimental and animal models, it reduced lung inflammation and fibrosis. Nonetheless, the use of pioglitazone in patients with diabetes and COVID-19 is controversial because of the risk of fluid retention and edema, especially in unstable or hemodynamically unstable patients. This cartoon shows hypothetical interactions between DPP-4 inhibitions and infections such as COVID-19 in persons with diabetes. In the upper part, this shows the initial concerns for possibly increased risk of infection, whereas in the lower part, expectations that DPP-4 inhibition might improve the prognosis of patients exposed to COVID-19 through various yet to be confirmed mechanisms. Because of the divergent and inconclusive findings derived from studies, definitive answers will only be provided by randomized controlled trials. For this reason, at least three parallel group randomized controlled trials investigating the effects of DPP-4 inhibitors in the prognosis for COVID-19 are currently ongoing. Two of them are looking at the effects of linagliptin added to background insulin therapy, and one in the US, the other one in Israel. And the third one is the open label effect of sitagliptin treatment in COVID-19 positive diabetic patients, or the SIDAIACO randomized controlled trial in Italy to evaluate the effect of sitagliptin as an add-on to standard care with nutritional therapy with or without insulin therapy. So it has been hypothesized that thanks to the ancillary effects of DPP-4 inhibitors, it could potentially be repurposed as salutary drugs against COVID-19, even for patients without diabetes. Interestingly, DPP-4 inhibitors are known to be associated with low or little or without any risk of hypoglycemia, which means that they could actually be used for safely in patients without diabetes. Clinical studies, however, need to specifically be designed to investigate this possibility, but currently, to our knowledge, none is yet underway, at least to test this hypothesis in patients who still without diabetes. Having said that, is there a possibility of saving individuals from diabetes? For persons with diabetes, which meds could give higher chances for remission? We know already that beta cell dysfunction, or when 50% of the beta cell mass is lost, diabetes gets diagnosed. What current therapies actually improve beta cell function? This cartoon or this graph shows the combined weighted mean differences of homeostatic model of assessment for beta cell function, or HOMA-beta, for various comparisons are plotted on the ordinate and combined with a WMD of pro-insulin to insulin ratio that are plotted in the abscissa. The center of each circle represents the combined WMD of HOMA and PIR. Perpendicular and horizontal lines represent the 95% confidence intervals for HOMA beta and PIR respectively. Approximate number of patients in the sample is shown in the area of the circle. Note that an increase in HOMA beta and a decrease in PIR are associated with amelioration of beta cell function in patients with type 2 diabetes mellitus. In this study, the results of HOMA beta and PIR consistently showed superiority of DPP-4 inhibitors over alpha glucosidase inhibitors, but inferiority of DPP-4 inhibitors to GLP-1 analogs. However, PIRs showed inferiority of DPP-4 inhibitors to metformin and superiority over SGLT2 inhibitors, while HOMA beta showed no significant differences in these comparisons. On the other hand, no significant differences in the change in both HOMA beta and PIR were observed between DPP-4 inhibitors and sulfonylureas, as well as between DPP-4 inhibitors and thiazolidinediones. This table shows the results of the cosmetic study, or factors predicting therapeutic efficacy of combination treatment with sitagliptin and metformin in type 2 diabetic patients. In this study, HOMA index or insulinogenic index or IGI were used to evaluate the pancreatic beta